So if you feel it's too basic for you, feel free to leave. Uh, the fact is that there are some concepts which people high up in their career also have not understood. So it's better to sort of go through basics, and once you're set with your basics, we'll move to the higher level. What I'm actually going to say is what I do for MBBS students. But still, there are some people who miss it and so or need a revision of it. So, in fact, yesterday I took a class for MBBS students where I covered nearly the same thing. So, we'll start off with the conduction system, few basic concepts. The first thing I want to ask you is about sinus rhythm. So, what in your opinion is sinus rhythm on an ECG? Sorry? Rate and rhythm is normal. Okay, so what do you mean by the rhythm being normal? So you're given an ECG and you have to look at it and say it's sinus rhythm. What is your basis for saying it is sinus rhythm? Equal interval between QRS and PR interval is what? P wave will be present in the second lead. So he's saying P wave is there in lead 2 means it's sinus rhythm. Is that, did I get you right? What's your opinion? When do you say it's sinus rhythm? So if you see a P wave, it's sinus rhythm. Okay. So so this is the heart, and here's your sinus node, AV node, bundle of his, right bundle branch, left bundle branch, left anterofascicle, left posterior fascicle. Okay. So I have a focus here in the atrium. The sinus, what's the normal sinus rate? 60 to 100. So 60 to 100, it can go up to 180 if your sinus tachycardia, it can go down to 35-40 sinus bradycardia. If I check your ECG at 3 a.m., it will be probably 35-40. That's not abnormal. I've had pediatricians, because they are pediatricians and they have just had a just born baby, checking their baby's heart rate out of curiosity and finding it is low and getting very anxious. But in the night, the rates will be low, right? So this cardiac conduction system, and let's say the sinus node is firing at 70 beats a minute, and there is an irritable focus in the atrium which is firing at 90 beats a minute, right? So obviously that focus is going to overdrive and take control of the kingdom, right? So you have this guy firing, coming down AV node, coming down bundle of his, coming down the bundle branches, right? So is that sinus rhythm? You're saying it's not sinus rhythm. Will there be a P wave? There will be a P wave, right? Because it's a focus firing in the atrium. It's going to capture atrial muscle. There will be a P wave, but it's not sinus rhythm. So what's sinus rhythm in your opinion? P wave originating from the SA node, okay. Followed by QRS, okay. Anything more to qualify? So we've now progressed from initial statement was P waves are regular, then another statement was QRS are regular. Then there is the statement that it's coming from the atrium. Now we have said it's coming from the sinus node. And we also have P waves are regular, followed by QRS. So PPs are regular. Okay, and every P wave is followed by a QRS. All right. So we've made significant progress towards the definition of sinus rhythm now. So now the next point is, so they said P wave is coming from the sinus node. They said P's are regular. They said QRS are regular. And they said that P is followed by QRS. Anything more to add to that? Sorry? Goes through the AV node. Okay, yeah, but that's a little hard to, yeah, you can add that in. The PR interval? Sorry? Yeah, the PR interval will be fixed. Yeah, PR interval will be fixed. Okay. So we've now essentially defined sinus rhythm, saying P's are regular, QRS are regular, P is followed by QRS, PR is fixed, and the P is coming from the sinus node. Okay, now your question is, how do you say P is coming from sinus node? Morphology. What's the morphology? 2.5 mm. Okay, fine. That's interesting. So I have a P wave firing from here. It's an atrial tachycardia or an atrial rhythm, not necessarily tachycardia. It was again more than 120 beats or something. You'll call it an atrial tachycardia. So atrial rhythm. And if I'm looking at lead 3, I will get a P wave looking like this with your 2.5 squares being satisfied. Does that make it sinus rhythm? Yes, no. V1 will be biphasic. Why is it biphasic in V1? You should not mug it up. You should just understand it. Why is it biphasic in V1? Yeah, I just cannot by heart these things. So you should do the same thing. Just understand it. Then you will never forget it. If you mug it up, you will forget. Okay, so we'll come to that point. So we've clear that to define that it's sinus rhythm, we have to look at the shape of the P wave, the appearance of the P wave, right? So if I say that is Hamsavardhani, why do you say it's Hamsavardhani? Because it looks like Hamsavardhani, right? The shape of the nose, eyes, face, body is like Hamsavardhani. So same way you say it is sinus rhythm, that P wave should look like a sinus P wave. So for sinus P wave, so now we are moving on to describing how a sinus P wave will look. So for how a sinus P wave will look, one point that she mentioned is that it is biphasic in V1. So now, why do we say, why is the P wave biphasic is the next question. So why is the P wave biphasic in V1? So firstly, what is V1? What lead is it? It's a right-sided lead. Excellent. Anything more to qualify it? Apart from it being a right-sided lead? Sorry? Anything else about V1? Right-sided lead, correct. Very good point. In fact, the only lead which is on the right side among the traditional 12 leads. Sorry? It's a chest lead. So what's special about these chest leads? In what way are they different from the limb leads? Sorry? Unipolar, unipolar. So what is this meaning of this unipolar? So I'll illustrate that with a point, right? So let us say that you are one particular point and he is another point, right? Two of you are two specific points. And she is sitting between the two of you and she's singing a song, right? So she's singing a song between the two of you. If I place a point at you and another point at her, I will hear what she's singing, right? Now, I also have a loudspeaker, much louder than her, which is blaring music from where isolation ward is. Okay? So what will you hear? You will hear the sound from the loudspeaker. You will also hear her song. What will you hear? You will also hear the sound of the loudspeaker. You will also hear her song. Okay? Now, when I look at the difference between what you hear and what he hears, what will get eliminated? The loudspeaker will be heard almost at the same intensity by both of you, right? Depending on how close each of y'all are to her, you'll be hearing her differently, right? But the loudspeaker will be almost the same at both of you because coming from far away, it's a loud noise. I am eliciting the difference between what you hear and she hears. That way, I eliminate that loud noise that's coming from far away, and I pick up only this thing, the difference between how you hear her and how she hears her. So I'm sort of fine tuning what I'm hearing. So that is what a bipolar lead does. So a bipolar lead will pick up what's happening between them. So the big advantage of a bipolar lead is it eliminates the faraway noise, right? So you have somebody lying down and you're recording an ECG. You also have an AC generator nearby or some other source of electrical noise nearby that will get eliminated because there's the loud noise that's going to be heard by both of them. So it'll get eliminated. So you're checking lead one, left hand, right hand. What is happening between left hand, right hand will be heard. You have, say, some other source of electric generation nearby, like the person is operating some electrical equipment or there's a hair dryer being used, that will get eliminated because it's going to be picked up by both these identically. Got that? Whereas a unipolar lead will pick that up. That's the problem about a unipolar lead. It will pick it up. Yeah? Now, there's another, so that way unipolar lead is disadvantageous, right? It's disadvantageous because it is picking up the outside noise. It's picking up the outside noise. That's the disadvantage of the unipolar lead. Now, bipolar lead is picking up the difference between him and him, right? What you sang, how they differently heard it. That's what it is. So essentially you're having a wavefront traveling, it's picking up the difference, right? Now, sometimes it can be very difficult to say whether the wavefront is coming like that or it's coming like this. You don't know. It's picking up the difference. So it doesn't give you the exact direction of the wavefront. It's not very easy to ascertain the direction of the wavefront, right? Whereas unipolar lead, it's me listening to music. I can straight away say she's singing from in front of me. I will not say she's singing from behind me, right? Just me, only my one lead. She's singing. I hear it straight off. I know she's in front. It doesn't seem like she's coming from behind. So unipolar will give me the direction, right? I know where she is, the location, right? So if she moves further away from me, I know the source is going far away. If she comes closer, I know she's coming closer, right? Whereas these things are not so easy to ascertain from a bipolar lead because it's looking at the difference. So if she's exactly equidistant from both of them and keeps moving, maintaining the same distance, the difference is going to be the same. So you won't be really sure about the location from where it is coming. Understood? All right. So V1 is a unipolar lead and V1 is a right-sided lead. Okay. Then how does V1 look at the body? How is it looking at the human body? Yeah. Septum. So can you just stand for a minute if you don't mind? Let's come over here. Yeah. So it's very, very important for you to sort of picture this in your mind when you look at leads. Yeah. So every lead you should look at it like that. That picture should come into your mind. So all the chest leads are looking transversely. So it's like me taking an axe and slicing through him, right? That's how the chest leads are looking. They're all looking like that, right? So if it is V1, V1 is sort of sitting like this and looking from here, right? So you just be straight, yeah. So V1 is sort of looking like this. So looking through him like that. And then V2, V3, V4, V5, V6 are all going around like that. Now, how does lead 1 look? So lead 1 is looking like this, right? That's how lead 1 is looking. So looking straight through. It's a bipolar lead. This is the positive lead, that's the negative pole. So if current travels towards this pole, it records as a positive deflection. Traveling away, it records as a negative deflection. So lead 1 is looking like this. Now the chest leads are all looking in this plane, whereas the limb leads are all looking in the coronal plane, right? Coronal plane, sagittal plane, you learn in your first week of anatomy. So like that. So this is a coronal plane. So if I take a slice and cut through this coronal plane. So all the limb leads are looking in the coronal plane. So lead 1 is looking like this. All right. What about lead 2? So lead 2 is looking like this, right? So this is how lead 2 is looking. Very, very important. So lead 2 is looking like this. This is exactly how lead 2 is looking. What about lead 3? So lead 3 is doing the exact mirror image of lead 2. So it's looking like this. Yeah. And what about AVF? Looking right from between his feet up. Looking from between his feet up. What about AVL? So AVL is sort of looking from over his shoulder, like that. That's sort of how AVL is looking, right? AVL is looking like this. And AVR is looking like that. right, from over this shoulder. Yeah, so you should have that clear in your mind. So it's like cameras, and each camera is looking at one particular aspect of the heart. So you get the whole picture when all of them give you information, right? So that is the big importance. There are pediatricians here, right? Nobody? No pediatricians? Ah, right. Very good. Yeah, so that's very important for us to know and get all the information we need. So if you have one lead strip recording, it's useless. As good as putting into the dustbin, like, because you don't get any information from that, right? So you'll have patient having some abnormal rhythm, and some smart aleck will immediately press the defib machine and get that recording. It'll come one strip, and then they say, oh, this is what happened. This is arrhythmia the patient had. That doesn't give you any information, right? It's like asking the blind man to feel the elephant, and he feels the leg and says, it looks like a pillar. Right? Only if all the blind men given their inputs, you know the exact shape of the elephant. So it's like that. So the reason I said specifically ask the pediatricians is because we have lots of kids who come to emergency and the ECG is either lost or not recorded or not uploaded, or you may just have a single strip. And if it's an SVT, it will not kill the patient. And 99% of arrhythmias are SVT, whether it's adult or pediatric. So like we have referred pain, there's referred anxiety usually that happens in the ward from the nursing staff, because they panic when somebody's in SVT, and then that reflects onto the doctor, and the doctor will immediately do a CSM or do something to terminate the arrhythmia. And then they'll promptly call us and say, oh, patient had arrhythmia, please come and opine. And we don't have anything to go by, right? Whereas if we have a 12-lead ECG, we'll know whether it's coming from the left side, it's coming from the right side, whether we have to do a septal puncture. All these things have implications in terms of prognosis, risks, etc. when we talk to the patient. So otherwise, we just tell the patient, you got a problem, you need an ablation. It can cause, it may need septal puncture, it may cause death. You talk all the risks, which is stupid. On the contrary, you will say, there's a risk of damaging your AV node if you think it's an AV NRT, or you say you have to go to the left side for a septal puncture if you think it's a left-sided pathway. And you can get all that information from a 12-lead ECG, which you otherwise lose. So don't panic when patient has SVT, or rather don't have the referred pain from the nurses, the referred panic. Just tell the nurses, cool, nothing to worry, hold their hands, comfort them, and just wait for the ECG technician to come and record the ECG. And also understand that if your heart is going at 72 times a minute with a blood pressure of 90 systolic, which is sort of the blood pressure of most Indian women, right? If she went into SVT, it's going to be 75 systolic. That is not hypotension. Her normal BP is 90 systolic. You just go out and take Kaniama or Muniama on the road, it will be 90 systolic will be the BP, unless she is hypertensive, right? So don't think that's hypotension and then immediately jump and cardiovert and do all that. That's just SVT, just chill. Nothing will happen. SVT will not kill the patient. Unless patient has already got severe ventricular dysfunction, that's the only time where SVT can be dangerous, which is very rare. Yeah, it takes some time for somebody to be in SVT to develop ventricular dysfunction. All right. When I say time, we're talking about 2 days, 48 hours or more. That's incessant SVT. All right. So we were talking about leads, and we're saying that they're like cameras and they're looking at the heart. Now it's again very important for you to understand, if multiple people say the same thing, then that's probably the truth, right? So, for example, you say that she's pretty, it doesn't mean she's pretty. But you say she's pretty, I say she's pretty, she says she's pretty, she says she's pretty, then she's probably pretty, right? So multiple people should say that thing, then it's true. And when you look at people who are friends, why are they friends? Because they have similar properties, right? They like the same person, they like the same behavior, they like the same kind of clothes, they like shopping together, they like going to certain places together, they have the same hobbies. So they have a set of common properties, right? So same way, when you look at leads, you must understand which are the leads are friends. And you should always look at leads in that fashion, okay? So, for example, when you look at the inferior wall of the heart, you are immediately thinking of 2 AVF-N3. So 2 AVF-N3 are all looking at the inferior surface of the heart. It's just that 2 is looking from this aspect, AVF is looking from right center, and 3 is looking from that aspect. So obviously, all of them should sing the same song. They're all friends. So you can't have a deep Q wave in lead 2 with no Q wave in 3 and AVF and say it's an inferior wall MI, right? If If you want to say inferior MI, all three of them should be singing the same song. You can't have only one guy saying she's pretty and everybody else saying no, and then you agree she's pretty. Right? So that's very, very key. So when you look at an ECG and somebody throws an ECG at your face, you start off by looking at leads in groups. You don't just blindly run through the ECG. So you will see 2, 3 AVF together. You will see one AVL, V5, V6 together, because they're all looking at the lateral aspect of the heart. You look at V2, V3, V4 together and add on V1 to it, because they're looking at the anterior surface of the heart. And you will not forget to look at AVR, because that's also important, and we'll come to AVR after some time. So that is very, very key. So this, you have to sort of make it into a habit. So when somebody gives you an ECG, you will immediately look like these three guys, then these two guys and these two guys, then these guys. You know, that's sort of how you should look. You should not start looking like this, like this, like that. That's not the way you look. You look at 2, 3 AVF together. Then you look at one AVL, V5, V6 together. Then look at V1 to V4. That's sort of how you look at an ECG. So that you should train and get that into your habit. Please sit down. Thank you so much. All right. So we spoke about leads and we spoke about sinus rhythm is what we were speaking about. Yeah. And we were speaking about lead V1. And we said that lead V1 was a biphasic lead. And we said it was a right-sided lead. And we said it was a, sorry, not a biphasic, sorry, it's a unipolar lead. It's a right-sided lead. And we said it is biphasic in V1, the P wave. Sinus P wave is biphasic in V1. And then the question was, why do we call it, why is it biphasic? That was the next question. So for that, now supposing I get angry with him. Yeah, I get angry with him and I've got a knife in my hand. And this as long as the knife blade is, right? And I go and I stab him here, right? This whole thing has gone inside him. Will he be alive? This whole thing has gone inside him. I've stabbed him here, just next to the vertebral column. Will he be alive or not? Huh? He'll die. Okay. Why will he die? Huh? Because I have pierced his heart. Okay, so where in his heart have I pierced? Left atrium. Yes, I pierced his left atrium. So again, going back to anatomy from your anatomy days, thorax, the most posterior chamber of the heart is the left atrium. The esophagus just in front of it. Just in front of it, esophagus, right? So, sorry, the esophagus is just behind it. The left atrium is just in front of the esophagus. So, if this was the cross section and this is the vertebral column and the spine, then your heart will be like this. This is how the heart will be. Okay. So if I was piercing him like this, I'll go straight into his left atrium. Yeah. Okay. Now, having spoken about the heart, the SA node is located between the SVC and the RA. That junction is where it comes. Where in the RA does the SVC join? Anteriorly, posteriorly. So right at the back. Okay, SVC and IVC both come right at the back. Okay, so your SA node is sitting somewhere here. Okay, this is sort of where your SA node is sitting. Okay. Now we have two rooms, this room and the next room. If I start singing over here, y'all will hear it first, then the people there will hear it. Y'all are in the room where I'm singing, right? So same way, when the SA node fires and the impulse is traveling to depolarize the atria, it will travel to depolarize the right atrium as well as to depolarize the left atrium. But it is already inside the right atrium only, right? So it starts depolarizing right atrium and eventually also goes on to depolarize the left atrium. Okay, and your friend V1 is sitting over here. So you will have right atrial depolarization And how will that look in lead V1? Positive, because current is traveling towards V1. So your right atrial depolarization will be positive. But within very few milliseconds, like you're looking at 10 milliseconds or even less, the left atrium will start depolarizing, right? Because it's going in that direction. Left atrial depolarization is going to be how in V1? Negative, because going away from V1. So left atrial depolarization will be negative, but it's a little bit later than the right atrial depolarization. So if this is the onset of right atrial depolarization, this will sort of be the left atrial depolarization. Now remember, another basic thing is when you are recording an ECG, it's like you sitting in moon and looking at Diwali being celebrated on Earth, right? So if you actually in moon sit during Diwali and see Earth, you'll see the entire India lighted up because everybody is bursting crackers. But you won't be able to appreciate whether he's bursting a cracker or he's bursting a cracker. But you can say that the whole of India is celebrating. The same way when you're doing an ECG, you're looking at the sum total. You're not looking at right atrium, left atrium, this guy, that guy. You're not looking. You're looking at the whole of atrial depolarization. So you're basically looking at addition of these two guys. And so because you're looking at addition of these two guys, you will end up having the initial part of the P wave being positive and the latter part being negative. And so your P wave in V1 is biphasic when it is coming from the sinus node. Make sense? So you don't have to mug it up that it's biphasic. It's biphasic because of this. It's very obvious. All you have to do is remember me stabbing him, right? And then you know that left atrium is the back. Sinus node is there. So current has to go forwards as well as backwards. So it goes forwards, giving the positive deflection in V1, goes backwards, giving the negative deflection in V1. So it's biphasic. Clear? All right. So now we know how the P wave looks in V1. But that is not enough to say it is sinus rhythm, right? Because imagine another focus, another tachycardia focus that is sitting, say, here, or for that matter, here, or for that matter, here. All those guys are also going to be biphasic, right? On ECG in V1. Any of them are going to be biphasic. So you have to figure out, you need better definition. You can't say that she is Hamsavardhani just because her nose looks like that. You have to describe other features as well to get the full picture, which is why you need multiple leads. One lead is not enough. So what more to say it's sinus to you? That has already been said. We are now describing the shape of the P wave. QRS preceded by P, all that we have already accepted. We've not now we have reached the point where we've defined everything. The only thing left is to define the shape of the sinus P wave. And in that we said it is biphasic in V1. What are the other features of a sinus P wave? Where? Upright in all leads. Except V1. I don't agree. You can go lead by lead. You don't have to make one all encompassing statement because that's always prone to make mistakes. Just say one lead and how it will be. Oh, sorry, positive P wave where? One should always have a positive P wave. Okay. Anything more? Morphology should be same where? Rhythm strip. Yeah, that's it has to be this. I mean, he said one is positive. Anything you have to add to that? V1 biphasic, one positive. Area under P wave should be? That is not really helping at all. No, because anywhere you are firing, it depends upon where your focus is. You can have multiple foci which give the same area. All right. So now going back, so you guys actually were not. I mean, some of y'all went through NEET for MBBS. Some of you didn't go through NEET for MBBS. So you're sort of this way and that way. I knew this was a permanent marker. Can somebody just call that guy? He told me this is a temporary marker. I knew it was permanent. Okay, so right? So in your 11th standard in NEET, right, you have this motion in one dimension where you talk about a child pulling a toy car and walking along, right? Pediatricians will be using that in their milestones and all that. Yeah, so when you talk about that, you will immediately say that there's this angle theta, right? Angle theta. Remember angle theta? And remember sine theta, cos theta, tan theta, trigonometry. Sine theta is opposite side by hypotenuse, cos theta is adjacent side by hypotenuse, right? So you look at that and then you say, you know, the component of the force, right? So you say this is F, force is F, and then you talk about the two components, F sine theta, F cos theta, and you sort of describe the two components, right? So this child is pulling this toy car and walking in that direction. So there's a force being exerted like that. And you'll break down that force into two components, right? So in these two components, you'll say there's one component like this and one component like that. So you resolve the force into two components, right? Now, as an extrapolation of that, yeah. So now we are looking at force like this, and we have resolved it into two components, saying one component is like this and one component is like this. Now this is basically vectors, which is also 11th standard chapter for you. I mean, was a chapter for you. So you're resolving it into two components, and I can change these two components in which I want to resolve it. For example, I can make one component like this and another component like that, right? I can make one component like this and another component like that. So I can change the two components of the force into which I'm resolving this given force, right? Now I can keep, for example, I can keep changing this into its two resolutions by making one like this and one like that, right? And imagine if I keep reducing this theta more and more and more like this, right? So this was this plus that. I now made it this plus that, right? One like this plus one like that. And if I keep reducing this more and more and more and more and more, till it comes in line with the green line, will I still have two components? No. What happens to the other component? It becomes zero, right? It becomes zero. So if I break it into two components like this, I have two components. As I keep making this almost aligned with this green line, it becomes one component. In other words, it is 100% on this and 0% in the other axis. So what I'm trying to say, or what I'm trying to convey, is that for a given force, if you went exactly perpendicular to it, the component of that force perpendicular to this force is going to be zero. There'll be no component perpendicular to it. Did you get that concept? Yeah. So he's sitting here and I'm pulling his hand like this. Okay. So if you look, there will be a component of my force this way, there'll be a component this way, all that will be positive. There'll be a positive component. But if you look at 90 degrees to him, there'll be no component. Okay. Now, what about if I looked behind him? I am pulling him like this, but he's looking at the component in his direction. What is that force going to be in his direction? Exactly. It's going to be negative. So if I'm pulling him forward this way, it's going to be negative that side. So if I dropped a perpendicular to him, it was zero. If I went anywhere in front of the perpendicular, there's going to be some positive component. If I went anywhere behind the perpendicular, it's going to be negative. My direction in which I'm pulling him is like this, right? So if I measured exactly like this, it's going to be the most positive, right? It's exactly in that axis. If I was looking like this, it will be positive, but a little less positive because one component of it. There are two components. I'm only looking at one component. If I went like this, Again, it will be positive, but it will be less positive. Does that make sense? From that vector picture I showed you of the child pulling the toy car. So the direction of the force is where the maximum is. So the child was pulling the toy car like this. If I measured here, it will be full positive because the perpendicular component has become 0. If I measured in this plane, it's going to be 0. On the contrary, if I measure from here or here, I will still be positive. But I won't be as positive as if it was this. Because this guy has got broken down into this plus that. This guy has got broken down into this plus that. So there'll be only one component of it which is coming this way. Understood that? Basic concept? Yeah? Clear? So we're basically talking vectors. We're talking about the direction of the force. So the direction of the force, when you are recording it, will be max if you're in the axis of the force being applied. It will be 0 if you are perpendicular to that axis. It will be negative if you are behind that perpendicular. Clear? All right. So now that we've got that sorted out, this is the sinus node. We're talking of only atrial depolarization. And we're talking about limb leads. So we're looking at the coronal plane, not the transverse plane. Transverse plane, we already finished that story. We looked at that picture, cross section, stabbing him from the back, and why the P wave was biphasic in V1. We already described that. Now we are looking at coronal plane and the limb leads. So we're looking at coronal plane and limb leads. If this is the sinus node and we are talking only about atrial depolarization, we are not talking about ventricular depolarization. So we are only bothered about how the P wave looks. We don't, at this point, we're not talking about the QRS. So when you have the P wave being formed, the net direction of current through the atria is like this. Does that make sense? Because obviously the source of current is above. There is so much of kingdom for it to capture. And it's going down the AV node into the ventricles. So it is obviously going to come like that. There'll be some amount of current traveling like that, some amount of current traveling like this, etc., etc. But the net purpose is for it to go down that way, right? So this is your axis of electric current when you are looking at the coronal plane. It's like this was the axis in which the force was being applied when the child dragged the toy car. So now, who is in line with the axis? Lead 2, right? So lead 2 is absolutely in line with the axis, absolutely aligned to the axis, right? So it's like when we were kids, it's not so much nowadays, but when we were kids, particularly in the LKG, UKG, this particularly among girls, when they start off, one girl likes another girl, her classmate in kindergarten, she will say pechu palam, she'll say, you know, which means she's totally aligned with that girl. They're like totally friends. And when she doesn't like that girl, she'll say pechu ka, she'll say. That means, you know, with the totally enemies, like, right? So lead 2 is pechu palam with the direction of which current is traveling, right? They're just in love with each other, like current is going that way, lead 2 is there to receive it. So what does that mean? It means you will see the most beautiful P waves in lead 2. Nowhere else will you see P waves as well formed as they are in lead 2. So you have an ECG and it's a tachycardia, particularly for the pediatricians, where their rates will be all 180, 190, 150, even without tachycardia. Just be sinus tachycardia going on at 200, right? Neonate sinus tachycardia will be going on at 240 in your neonate ICU. So you're lost. Where's the P wave? So where will you search? You will search in lead 2. Right? You hear the sound of hooves outside Asha building. You're not thinking it's a zebra or a giraffe galloping around, right? You're thinking it's a cow. If you're in Africa, you'll think like that. So same way, when you have to look for a P wave, you will look for it in lead 2. You won't go looking for it somewhere else. Right? So lead 2 is where you will search for your P waves. When you're thrown an ECG that you sort of hits you and you're sort of have no clue where to look, you will look for it in lead 2. All right. So this is your axis of current. And obviously, you have to go perpendicular to that axis, and anything on this side of the perpendicular is going to be positive. Some positive component is going to be there, which is why lead 3 will also be positive and lead 1 will also be positive, because they are all coming within that range, right? But who will be negative? AVR will be negative, because AVR is the only guy sitting over here, and the direction of current is absolutely peche ka with AVR, right? So it's going away from AVR. It's an enemy of AVR. So AVR will be negative, right? Now this is true whether it is atrial depolarization or whether it is ventricular depolarization. Because ventricular depolarization is what gives you your QRS. And ventricular depolarization is also going in that same direction down, right? It's also going like that, right? So ventricular depolarization is also going to be towards lead 2 and going to be away from AVR. So your P wave will also be negative in lead 2. Your QRS will also be negative in lead 2. Sorry, in AVR. All right. Okay. So which lead is sort of perpendicular to lead 2? Sort of, not necessarily. AVL, right? So in AVL, you may not see so good a P wave. It may be some shady, mushy P wave, not a very striking P wave like you see in lead 2, right? Now you must understand that the heart is not going to be fixed exactly aligned towards lead 2 in every human being. It may be a little bit this way, that way, which is what makes medicine not like maths, right? You can explain anything with everything. So because of that, don't get depressed if things are not how you expect it to be. So I said AVL should be a mushy P wave, but sometimes you may see a reasonably better P wave in AVL, because AVL is not exactly perpendicular to the axis in which current is traveling in that individual. Yeah. But by and large, the P wave should be well formed in lead 2, positive in 1 and 3, negative in AVR, biphasic in V1. So you can go on describing it in all 12 leads, but it is, I mean, for convenience sake, we stop with so many leads because this gives us enough information. It's unlikely that we will be taken for a ride if it satisfies all these criteria. There are still exceptions. Like for example, you have a P wave being generated from the right superior pulmonary vein. If you remember your thorax, the right superior pulmonary vein is sitting just behind the SVC and where the SVC and RA join. So a focus sitting in the RSPV will look just like sinus tachycardia. Very difficult to differentiate. So you use all these leads, you'll still be fooled. You'll think it's sinus tachycardia. So how do you differentiate? Atrial tachycardia coming from RSPV, particularly seen in the pediatric population. So how will our pediatricians differentiate? So actually, they never differentiate, and we also are not able to differentiate, and that's because we don't have equipment. So this is a point to tell your superiors to get the equipment. So basically, you need to have that big screen which records, like a Holter recording of the tachycardia or the trace, so that you can go back in time and review. Now, what you currently have is a monitor, but that monitor doesn't give you old information. It will give you the heart rate as a number, which can be fooling you. You need to see the rhythm strip. So you should sort of have a rhythm strip to go back and see. And any arrhythmia will have a sudden onset and a sudden offset. It won't gradually go up and gradually come down. So if it is sinus tachycardia in a child, you would probably see rates 180, 185, 190, 195, 200, then comes back after some time to 195, 190, 185, like that. Whereas if it is an arrhythmia, it will suddenly shoot up from 120 to 195, then maybe go 198, come down to 193, but be oscillating around that 195 for a while, and then suddenly come down to 120. So that sudden up and down, you can pick up only if you have that recording, which is what makes it very important. Because at this point of time, you're seeing the rate is 195. That doesn't help you. So if you know the trend, whether it abruptly went up or gradually went up, then you will know that this is an arrhythmia and that was a sinus tachycardia. Now that's very important for you all also in your medical ICU. Because you'll have somebody on sepsis and you start the person on inotropes, the rates will go up, and then you will think it's actually an arrhythmia when it's not an arrhythmia, it's just sinus tachycardia. All right. So we spoke about that. So far, we've spoken about the leads. We spoke about the 12 leads. We spoke about the P wave and how sinus rhythm should look. Yeah. Okay. So how are you all doing mentally and psychologically? Because I can go on even until 4 in the evening. I don't have an issue. But it matters how you all are doing mentally and psychologically. The other thing is, no, you will, even if you listen to 10 talks in ECG, you will not remember anything. You have to go on seeing ECGs. The way you learn ECG is going on seeing ECGs. So every ECG that's done, you look at it. And then if you have an issue or doubt, you ask somebody. The other big thing is to know whom to ask. Because there are a lot of people who will pose as if they know, but they actually won't know. So that is another level of discernment that you need to have. I remember when I used to go around asking people and they'll tell me some 3-4 words and they'll walk off and I'll be trying to figure out what those 3-4 words meant. And later on in retrospect, I realized many of those people were telling me wrong things because they themselves didn't know. Not that they wanted to mislead me, but they themselves didn't know. So it's important to know who knows and ask the people who know. It's very important. Okay, so how are you all doing psychologically, mentally? All right. Okay. So just wondering what to do next. I think I'll do access next. Yeah. So yeah. So for access, I have my famous story, which is a true incident, by the way, which was when, for those, I think many of you are not from CMC for your undergrad. The bottom line is undergrad students in CMC don't study. Yeah, they just fool around, right? So that has been true down the ages. Not like you guys who studied undergrad somewhere else where you all actually studied. Yeah, so our batch finished their final year exams. Final year MBBS is over. So after final year MBBS, they decided that they have to have fun. So there's this group of 5 boys in my class who decided that they want to go to Bangalore. Day after, like final MBBS exam is over today, tomorrow they're all going to Bangalore. Okay, so they're sitting in mess in the high table, right? Those of you in CMC will know the high table in men's hospital. So they're sitting in the high table, these 5 fellows, they're discussing their plans of going to Bangalore. Now these guys are going to Bangalore with only one objective. Yeah, what's their objective? They're going to see pretty girls. That's the only reason they're going to Bangalore. Okay. So they've figured out the area where they have to go. I believe there's some Brigade Road and MG Road. That's where apparently the highest probability of picking up pretty girls. Okay. So they're going there to see. Now suddenly they had an issue. These 5 fellows, you know, what if he saw more than me? And then after that, we come back and he says that girl, and I don't know which girl he saw. You know, so that was an issue. So then they discussed, hey, this shouldn't happen. You know, we all should have an equal opportunity. It's not like somebody sees more and somebody sees less. So then now they're so-called civilized doctors from CMC going there. They can't sort of look at a girl and, hey, look there. You know, it sort of looks very ugly. So they decided they'll be sophisticated about it. So they said, okay, we're walking down the road. We'll say that is 12 o'clock, that's 9 o'clock, that's 6 o'clock, and that's 3 o'clock. Right? So they said when they were walking, hey, 7 o'clock, right. Hey, 3 o'clock, oh, right. You know, so everybody manages to see everything, but in a very polished way. Yeah. So the following night, they all returned back, and I was with them at the high table, and they were all very happy because everybody saw everything and there was no discrepancy. The plan worked perfectly. Right? When one fellow saw 6 o'clock, everybody just saw 6 o'clock. When one fellow saw 3 o'clock, everybody saw 3 o'clock. So it just worked perfectly. Right? So the same way, the reason it worked perfectly is that they all had the same language. It's not like the American said something and the English said a different thing and so on and so forth. Right? Like program spelling in English and American spelling is different. It's like that. So that it's not like that. Here, everybody agrees that lead 1 is here, AVF is here, lead 2 is here, lead 3 is here. Everybody agrees. It's not that one guy says this is lead 2 and another guy says no, this is lead 2. Right? So what were these 5 boys doing? They were basically plotting the axis of the pretty girl with respect to themselves. Right? So pretty girl is there, that is the axis. Pretty girl is there, that's the axis. So that's exactly what they were doing. So when you talk about axis of an ECG, you're plotting the direction of electric current. That's all you're doing. And you need some ground rules. Like they laid the ground rules, which is 12 o'clock and which is 3 o'clock and which is 9 o'clock. They laid the ground rules. Right? So you have to lay the ground rules. So the ground rules are that this is lead 1 and that is 0. This is AVF, it's 90. Right? Everybody agrees. Nobody disagrees on that. So once you have that, you can figure it out. So that's basically what they did. So this is your lead 1, which is 0 degrees. This is your AVF, which is 90 degrees. You can call it as 12 o'clock and that is 3 o'clock or whatever way you want to call it. But essentially, this is 0, this is 90. Right? Now, when we talk about axis, you can look at axis of P waves, you can axis of QRS, you can look at anything's axis. But by and large, we are interested in the QRS axis because that's ventricular depolarization. And you're looking at the direction in which the ventricles are getting activated. That's sort of what we're looking at by and large. So like I already told you, the ventricular depolarization obviously will be in this direction because the left ventricular mass is much more than the right ventricular mass. So it's going to take more time and more current is going to go in that direction. So that's the direction of ventricular depolarization. So this is your normal axis. So if you were to look at lead 1 and lead AVF, only these 2 leads, current is going to be traveling in this direction. So there'll be obviously a positive component in lead 1. There'll also be a positive component in AVF because this is your 90 degrees to the direction of current and both these guys fall within that 90 degrees, right? So lead 1 will also have a positive component. AVF will also have a positive component, right? So both will be predominantly positive. And then you say that it is normal axis, normal axis. Now, supposing this patient had aortic stenosis, what will happen? LV hypertrophy will happen, right? So it's like the left ventricle is going every second of the day to the gym, right? So it is building its muscles up. So obviously your LV will become hypertrophied. So once the LV becomes hypertrophied, this heart is going to sort of get rotated, right? So it will get rotated and instead of being like this, it will sort of go like that, right? The heart will get rotated that way. Now, when I say rotated, it does not necessarily mean that the whole heart has to move that way, but just that the left ventricular muscle mass has increased so much that's going to pull the current vector that way because there's so much muscle here for it to depolarize in the free wall of the left ventricle, which will get really thick when you're having hypertension or you're having aortic stenosis. Anything which increases your peripheral vascular resistance will cause that. So automatically, when the depolarization is going to occur, it's sort of going to go in this direction because that's where the large mass of the left ventricle is sitting. So when it starts going in that direction, what about AVF? Is AVF going to be positive or negative? So I'm having too many pictures here, so it's a little confusing for you all. So that's how your heart is looking now. So we are saying that this is your plus red color pen irka. Red color. Illa adu permanent marker. Temporary. Oh. Okay. So this is your direction of current. Here is your AVF. Here is your lead 1. So now tell me, how will it be in AVF? It will be negative because this is your direction of current. So the moment you see direction of current, you plot 90 degrees to the direction of current, right? This is going inside this side of the 90 degrees. So obviously your AVF will have to be negative, right? What about lead 1? It will be positive, right? So lead 1 is positive. So AVF is negative, lead 1 is positive. These two guys are going away from each other. They don't like each other. That is your left axis deviation, right? So you look at the ECG and you see lead 1 and AVF, both are positive, you know your normal axis. Lead 1 is looking up, AVF is looking away, it's looking down, then you know it's left axis, right? All right. Now you can have the same thing, but changing the scenario, saying that patient has pulmonary stenosis or pulmonary hypertension, either one of these two situations. When that happens, what will happen? You will obviously have right ventricular hypertrophy. So when you get right ventricular hypertrophy, your right ventricle becomes very, very thick. So this guy will get very thick. He will pull all the current towards himself in this plane. So now the axis gets shifted like this, because the right ventricle has got hypertrophy. So right ventricle is pulling it like that, right? Because it's pulmonary stenosis or pulmonary hypertension. Right ventricle is struggling to push blood out. So the muscle is getting thicker. So it pulls the heart like that. So when it pulls the heart like that, your axis starts going like that in the direction of your lead 3. That's how it is going, right? So this becomes your direction of current. And immediately you think perpendicular to it, you think, right? Now, how will it look in lead 1 and how will it look in AVF? Lead 1 will be negative. So lead 1 becomes negative, whereas AVF becomes positive. So these two are trying to reach out to each other and kiss each other, right? So they're right with each other, right axis. So imagine this AVF is reaching up and lead 1 is reaching down so that their lips can meet each other, like, right? That's right axis deviation, Clear? Okay. So what have I left now in terms of permutations and combinations? Both positive, this guy positive, this guy negative, this guy negative, this guy positive. What have we left? Both negative, right? Both negative. So what does both negative mean? What does both negative mean? For both to be negative, how should the current be going? Yeah. If both are negative, it means current is going towards AVR, right? For both to be negative, current should be going towards AVR. Only then both can be negative. So this is your AVF, this is your lead 1. And we are talking about both being negative. So this is your 4 quadrants. So this is negative, this is negative, this is positive, this is positive. So both negative means it has to be going that way. So for it to go that way, we are talking about current traveling like that. Yeah. So what axis is that called? Yeah, northwest axis. You guys are all very smart. I never knew this northwest word at all. I was totally, flummoxed when one of these old people looked at these and said, oh, it's northwest axis, when I was at your stage in life. And I was totally clueless what he meant by northwest. Much later in life, I realized that this northwest comes from how in any map you'll have, this is north, this is east, this is south, and this is west. So anything that comes here is called northwest. This is by convention, right? Any world map or any map you see, it'll have this directions. So this is coming here, so he's calling it northwest axis. I had no clue about this. So northwest is basically that. Otherwise, it's called extreme axis, extreme, because totally horrible. You know, the only way current can go that way means your heart has done a somersault, right? Heart is like this. It's done an absolute somersault like that, right? That's when current will go that way. Why should current go that way? So it's extreme. It's not normal. So if you see positive QRSS in lead AVR, it means deep shit. Yeah, that's what it means. Yeah, very, very bad. When does that happen? Huh? Yeah, so if the heart is not displaced, very rare for the heart to do a somersault like that. It can happen if you have the normal heart, right? You have the normal heart, but the rhythm is not being driven from there. The rhythm is being driven from here. Something here is driving the rhythm. So he's driving the rhythm, he's calling the shot. So he's sending the current up, which means it has to be a ventricular rhythm. Ventricular rhythm, obviously either VT or VF or something like that. It has to be ventricular. So if you see AVR, nice, positive, and rate is high, gone. Bad scene. Then you should shock. Don't wait for ECG technician to come. Right? Okay. All right. So we spoke about axis. We spoke about sinus rhythm. For sinus rhythm, we said we are looking at the P waves. We described the shape of the P wave. We said the P wave should be positive in 1, 2, 3, negative AVR, biphasic in V1. We explained why it was biphasic. We also briefly spoke about unipolar and bipolar leads. We said that V1 is a unipolar lead, it's a right-sided lead. We said it's biphasic because initially current is traveling towards right atrium, then towards left atrium, and so it's biphasic. Then we also said that the leads are positive in 1, 2, 3, and negative in AVR. AVR is the only lead sitting there at the top corner. It's an orphan lead. It has no friends. We said that all the other leads have got friends, like 1 AVL, V5, V6 are friends, 2, 3 AVF are friends, V2, V3, V1, V2, V3, V4 are sort of friends. We said that we look at multiple leads. If all of them sing the same song, we say, yeah, the song is true. If 1 or 2 are singing a song and the others are not agreeing with them, then we'll be doubtful about any value in that scenario. We also spoke about the fact that the P wave should be regular, the PR interval should be fixed, the P is following, there's a QRS that follows every P wave to say it's a sinus rhythm. So those points were initially highlighted, and then we went on to describing the shape of the P wave to say it's sinus rhythm. So all that has to be satisfied to say it's sinus rhythm. Then we also looked at axis. We said what is left axis, what is right axis, what is normal axis, and what is northwest or extreme axis. We also described the importance of doing a 12-lead ECG and the fact that we shouldn't have referred panic and we should just hold ourselves and calm the nurses rather than doing keratosinus massage till the ECG machine comes and the ECG is being done. And when the ECG is being done, you do the ECG, you document the SVT, you keep the adenosine 12 mg ready with you. Okay, keep the adenosine 12 mg. 6 mg is enough if you're sitting in some foreign country where it's not adulterated. In our India, you usually need 12 mg to get a 6 mg effect, right? So you keep the 12 mg there. There's no need to lift the patient's hand and all. It's not going to sort of by gravity flow down faster by lifting his hand. The more important thing is to just make sure that you have your flush ready, your adenosine ready, have a 3-way ready, push with one, push with the other immediately after you flush it, right? And do that carefully so that when you're pushing, it is not locked and it splatters on your face. So those are the things to worry about, not lifting the patient's hand, because when you lift the patient's hand, all the ECG leads will move and the ECG recording will also become bad and you won't make sense of what you're recording. So leave his hand peacefully as it is and then give the adenosine. Now, the thing is that when you're giving adenosine, you should be doing a rhythm strip. Okay, when I say rhythm strip, not single lead again. So the ECG machines that we have in CMC are all capable of recording you a 6-lead rhythm strip. So ideally, you should choose those 6 leads where you see the P wave best. Because you want to know that when you terminate tachycardia, whether it's terminating with a P wave or terminating with a QRS, because that gives you a lot of information as to what the arrhythmia is. Right? So, as things stand, when you have a SVT, you will not be able to see the P wave. Or even if you see the P wave, you're not sure it's a P wave. But at least pick those leads where you think there is a P wave. Maybe that's the P wave, I don't know. So pick those leads. Right? So say you thought V1 had a P wave, then make sure V1 is one of those leads. You thought lead 2 has a P wave, make lead 2 one of those leads. So choose 6 leads, let that rhythm strip run, and as it's running, you give your adenosine. Then you will capture the termination. Even if it didn't terminate, it will have stopped for 1 or 2 beats and then restarted. That will give you information. What is the story it will tell you? Right? So in future, when you have an SVT, don't lose your cool. Just get the ECG technician to come and then give the carotid massage over the adenosine so that you have it recorded. Then you have a diagnosis there. Okay. All right. Then, so we finished. Okay. So then the only other thing I'll quickly tell you about is the AV node. Yeah. So the AV node is different in that it's got this property of refractoriness. So you stimulate it, it will conduct. You stimulate it again, it will conduct with decrement. You stimulate it again, it will decrement more. You again stimulate it, it will block. Unless, of course, you give enough gap and stimulate it when it will conduct all the time. right? That's the AV node's property. That's a very unique property. That's not there in other tissues of the heart. The AV node has got that special decremental property. Yeah, that's very important to understand. Now, why is the AV node having the decremental property? Why did God make the AV node like that? Yeah. So the one reason is to improve your diastolic filling, because the longer it takes for the impulse to travel from the atrium to the ventricle, all that is diastolic time. The longer your diastole, the more the ventricle fills. The more it fills, the more appropriate its stretch, as long as it is within physiological limits. And by Starling's law, we know that will improve the contractility, right? So I don't know if you guys had frog experiments. You all were at the time, and I think they were ending it and not allowing it anymore. Our time we did frog experiments, so it was very nicely. You could see that, as you stretch the muscle more, the contraction becomes more, because you'll record it on a drum. We used to have a smoked drum, which will rotate, and a needle. So you stimulate the muscle, and the muscle will contract. And then you stretch the muscle by putting some weights on it, and then stimulate it. It will contract even better, as long as you're stretching it within physiological limits. So you objectively see the demonstration of Frank-Starling principle. So the heart muscle needs to be stretched. Only then it will contract nicely. For that extra stretch, you need more diastolic filling. So for more diastolic filling, you need to give time for it to fill. Only then it will have more stretch. So that time is provided by the AV node, because that's the time when the filling is happening in the ventricles. And so that's one reason. The other reason why you have this AV node's role is to prevent drama from upstairs going downstairs. So what do we mean by that is that if you have an atrial tachycardia or an atrial flutter or an atrial fibrillation, all these things, the atrium are going at very rapid rates. So if it's a flutter, it is going at around 300. If it's a fibrillation, it's going around 600 times a minute. And all those impulses are going and knocking on the AV node to go down to the ventricle. So you all know that your heart is the size of your fist, right? That's the size of your heart. So if I ask you to do 72 times a minute, you can do it. If I tell you to do 180 times a minute, you can still do it, right? 180 times a minute, you can do, if you count and see. If I ask you to do 600 times a minute, you can't do it. At best, you can do this. That's 600 times a minute. So that is fibrillation, right? So when the atria are fibrillating like this, every single impulse of those 600 impulses are going to knock on the AV node. If the AV node allowed every one of that 600 down, then your ventricle will be doing the same thing. If your ventricle is doing like this, there is zero cardiac output. You will die on the spot. So like how we saw so many deaths during COVID, you'll be seeing deaths around, because there's so much of atrial fibrillation around. All of those will be dying. The reason they're all not dying is thanks to their AV node, which is God-given protection. It will allow first impulse down, second guy, third guy, fourth guy, it will block. Then it will allow the next one down. So your atria is going at 600 times a minute, your ventricle going at 150 or 180 times a minute, which is still reasonably compatible to maintain your cardiac output. Yeah, so that is the reason why you have that AV nodal Wenckebach property. It prevents drama upstairs getting transmitted downstairs and helps in providing you diastolic time. So this AV node, when the current is traveling through the AV node, there are cells depolarizing in the AV node. It's not that there are no cells depolarizing. There are cells depolarizing, but the rate at which they are depolarizing is very slow. So remember I told you, when Diwali is being celebrated and you're sitting in moon and you're looking at the earth, you'll see the whole of India lighted up. But let's say it is a month like now and there's some family celebrating their wedding in their family. They'll be bursting crackers. But you will not see that in moon, right? Because there's one family bursting crackers. You're not going to appreciate that. The same way, when current is traveling through the AV node, it's like one family is celebrating a family occasion, which you won't pick up on the ECG. So it will be effectively electrical quiescence, flat line. Doesn't mean that there's no depolarization happening, but there are just few cells in the AV node that are depolarizing, which is not enough to contribute to a deflection, which can be perceptible when you're recording your ECG. So it'll be a flat line. So that is why that PR segment is flat. PR segment. So P wave atria depolarized. Current is traveling through the AV node. At that time, you don't see anything. When it's traveling through the bundle of his, you don't see anything. Traveling through the bundle branches, you don't see anything. Traveling through Purkinje fibers, you don't see anything. Reaches ventricle, you start seeing your QRS. Right? So your In maths, you learn no line segment. Line segment is a straight line that joins 2 points. So PR segment is only the straight part. PR interval is curve plus part. That is the P wave plus the PR segment is your PR interval. So intervals always include waves. Segments are just flat line. There are no waves in there, right? So if you all have learned about the PR interval, it being around 120 to 200 milliseconds, right? PR interval. So PR intervals contributors are who all? Who all contributes to the PR interval? Atrial depolarization, AV nodal depolarization, His bundle depolarization, bundle branch depolarization, Purkinje fiber depolarization. All these guys contribute to your PR interval. All these guys, 5 players are there involved there, right? Atria, AV node, bundle of His, bundle branches, Purkinje fibers. All these guys contribute to the PR interval, right? So now coming to the next story. So imagine y'all are kids and y'all are going for a family function, right? So everybody has to get ready. If you are saying you're attending a marriage, everybody has to get ready and then you go. Now, different people take different amounts of time to get ready, right? So say the father of the house, he probably takes about 5 minutes to get ready or 10 minutes to get ready. The son probably takes 3 minutes to get ready. He thinks he's already ready. He's ready to go. The daughter is also technically thinks she's okay, but you know, the hooks at the back, she has trouble putting. So somebody has to help her putting those hooks in the frock at the back. So that takes a little bit more time. So she probably takes 10 minutes till she can find somebody to do that for her. And the lady of the house probably takes a little longer time to get ready. Like she probably wears one chudidar, then thinks it's not up to the mark, then she changes it, then puts one sari, then finally decides, okay, that sari is not so good, this is better and all that. So she takes half an hour to get ready. Okay. So when does the family go? They go after half an hour, right? Now let's say on another day, the so-called man of the house decided that he wanted to change his shirt and not wear the shirt that he originally wore. So he took 10 minutes to get ready normally. Now he'll take 20 minutes to get ready, right? He's chucked this shirt and changed to another shirt. Will that delay the time of the family going for the function? No, they will still go at 30 minutes. Let's say the next scenario, the lady of the house decides that she gets delayed for some reason. You know, she wanted to dress Western or dress Eastern or like how they do in women's hostel day, no? One day, one Western, one day Eastern, like that. So she decides to change altogether, right? So then what will the time be? Instead of 30 minutes, it will become earlier, later, it'll get later. So everybody gets later, right? So the rate determining step as to when the family went depends on who took the maximum time to get ready, right? That person determines. So in the heart, that is your AV node, right? So the biggest contributor to the PR interval is the AV node, the biggest contributor. Very important to understand that. Okay. So you have an ECG done. Yeah. And the PR interval is 350 milliseconds. 350 milliseconds. Bizarre, right? You say P wave and then QR is coming so much later. Right? Will you be worried? You will not be worried at all. You will very happily clear the patient and say, go for surgery because this is AV node block. No problem. AV node. So we have the various levels of hierarchy. So sinus fires at about 60 to 100. AV node is 45 to 60. That you learned in your physiology. In your first year, you learned in cardiovascular. Right? So you have a block in the AV node. There's a block somewhere here. The guys below it are not bad. They can manage the scenario. They will go at about 60. They will keep the rhythm going. Right? So you have an ECG with a bizarre PR interval. You will chill. Surgeons will call you. They'll frantically ask. Anesthetists will call you. You will say, cool, nothing to worry. It's AV nodal problem. Right? You can't blame anybody else if the family went late, right? The person who's taking 30 minutes is obviously the culprit if they ended up taking 45 minutes to come. You're not going to say, oh, the daughter took long time to dress or the son took long time to dress. Because as it is, that flow is taking 5 minutes or whatever. It's unlikely that he could have delayed it beyond 30 minutes. So if your PR is blown out to 350, you can't pull Mr. His bundle and say, hey, his bundle, you're at fault. Or you can't pull Mr. Purkinje fiber and say he's at fault. Those guys, as it is, take like 20 milliseconds or 15 milliseconds to depolarize. But the AV node, as it is, takes about 70 milliseconds to depolarize. So obviously, the AV node has to be culprit. He has to contribute to it. There has to be some contribution from him. His bundle is really rotten. Instead of taking 15 milliseconds, he's going to take 30 milliseconds. Is that going to blow your PR interval from 120 or 150 to 350? No. Understood. On the contrary, if your PR interval was like, 210 or 215, then you are not sure. It may be his bundle. It may be bundle branch. These guys may be at fault. Because a very small prolongation. You can't blame AV node for that. Maybe AV node also, but you're not sure. So if you see a PR interval more than 300 milliseconds, you are chill. Right? If it is between 200 and 300, you're not sure. If it is less than 200 and somebody tells you that there is a problem with AV conduction, then it has to be one of these bad guys. His bundle or bundle branch. Can't be anybody else. So the irony is, when the surgeon looks at the ECG, he will think it's perfect. The anesthetist will think it's perfect because PR interval looks normal. But you guys will say, no, I'm worried. Because PR is normal, I'm worried. Because now I know I can't blame the AV node for it. It's one of these other guys who are causing the trouble. And those guys are not reliable. Because if you have a disease in the His bundle, then you are going to the fellow below the His bundle. So there's a disease here, you are now downgrading to somebody below that. And that guy's rate is going to be 40 a minute. So though patient is now in normal rate, you don't know when he's going to go into 40. And if that happens on table in theater, then bad luck. Right? Got that concept? So we'll revisit this, what I'm describing, to see how you all are applying this knowledge with ECGs. Okay. Saturated? You have to call the shots. I can keep going till 5 o'clock, I told you. You won't remember anything. That's the problem. Unless you keep seeing ECGs. You have to keep seeing ECGs. Every time you see a ECG, see, okay, is it normal, abnormal? Start now when you go, you start seeing ECGs and try to see whether it's sinus rhythm or not. So start looking at V1, looking at 1, 2, 3, looking at AVR. Is it sinus rhythm or not? You start with that. Okay, once you figure out it's sinus rhythm, then start looking at other things. What is the axis? Is it normal axis, left axis, right axis, or extreme axis? You start there. So every ECG you start seeing that. It's a nice way to impress people. You just look at it, oh, it's left axis deviation. People, you all stunned. Oh, this guy knows so much. Like, all you did was look at 1 and AVF. That's all. So, okay, I think I'll stop. Oh, you want me to go on? No, I think it's not advisable to go on. That's what I think. I won't be able to sit through if I was you, though I'm able to talk through. Yeah, so shall we stop? So next time we'll look at some ECGs and see how you are applying what you listened to. One more concept I'll finish off that. So that way all concepts will be done. One more concept. Okay, so you know in Tamil Nadu, no? So there's this area in Tamil Nadu, that Poes Garden area, okay? That area will never have a power cut. Okay, that's because the current chief minister, the previous chief minister, Jayalalitha, everybody lives there. Rajinikanth, Kamal Haasan, you just drive that street, you'll see, oh, that's Kamal Haasan's, oh, that's Rajinikanth's house, oh, that's Purachi Televi's house, you know, everybody's house is there. Like. So that place will never have a power cut, come what may in Tamil Nadu. Okay, even if the Kalpakam nuclear power station shuts down, Neyveli shuts down, there'll be current. Okay. But God didn't make the human heart that way. The human heart is such that every nook and corner of the ventricle gets current at almost the exact same time. Right? Everybody gets current at the same time. Because you have a Purkinje fiber landing everywhere. Right? So this right bundle will give off branches, and the left bundle and left anterior fascicle will give off branches, and your left posterior fascicle will give off branches. So essentially, whether you're here or here or here or here or here or here or here, everybody will get current at the exact same time. That's very, very important to understand. So it's not that one guy gets current before the others. Everybody gets current at the exact same time. So in the kingdom of the ventricle, whether you're in Tamil Nadu or Kerala or Andhra or Maharashtra or Gujarat or UP, everybody gets current at the same time. So when Tamil Nadu gets current, he will depolarize. And when Andhra gets current, he'll depolarize. And when Karnataka gets current, he depolarizes. And when Maharashtra gets, he depolarizes. When UP gets, he depolarizes. When Telangana gets, he depolarizes. Everybody depolarizes. But everybody depolarizes at the exact same time. So because everybody is depolarizing at the exact same time, when you are recording your sum total of depolarizations while doing your ECG, basically sitting on moon and watching India celebrate Diwali, you will get a thin, tall, handsome QRS, right? You'll get a thin, tall, handsome QRS. But if say this person had some MI or sarcoidosis or tuberculosis or some reason for which this branch got affected, then UP and Bihar will get current late, whereas all these guys will get current on time. So you will have Tamil Nadu getting current and Andhra getting current and Kerala getting current and Karnataka getting current, whereas UP and Bihar will be a little late. So when you actually do your addition, you will end up getting a QRS like that. Yeah. So if you have an obese QRS, which is not handsome enough to your liking, it basically means all corners of the ventricle didn't get current at the same time, right? All corners of the ventricle didn't get current at the same time. What the reason for it is different. It may be TB, it may be sarcoid, it may be LV hypertrophy, it may be bundle branch block, it may be a careless surgeon, or it may be some cardiologist who did one TAVI and damaged the conduction system. You can have a whole bunch of reasons for it. But the bottom line is everybody didn't get current at the same time. That you should be very clear about. That is the concept. Yeah? Okay. The other thing is broad versus narrow. That's the other concept. When do you say it's a, so when you see a tachycardia like that, your first thing is to say whether it's a narrow complex tachycardia or a broad complex tachycardia. That's the first thing you have to say. You say it's a tachycardia, then you say whether it's narrow complex or broad complex. That's the next thing you have to say, because that will take you down different branches of thinking as to what is the cause behind it. So when do you say it's narrow complex? Less than 3 small squares, less than 120 milliseconds. So out of the 12 leads, if 3 leads are broad, more than 120, and the remaining 9 leads are less than 120, is it narrow or broad? Broad. So if one lead is broad and all the others are narrow, it's broad. So you're all clear about that concept? Makes sense? Does it make sense? Why is it broad? I mean, why are we calling it broad if one lead is broad? Huh? Yeah, one lead is only broad, no? All the others, majority is saying it's narrow. Why are you calling it broad? So this story will help you understand why, when you picture this, it makes sense to you. So in our time, all marriages used to be arranged marriages, by and large, right? So how's the process? Basically, say my mother interacts with prospective mothers-in-law and asks them to send pictures, right? So then they send a whole bunch of pictures, and then my mother looks at these pictures, and then she decides which of them she likes best, and so on and so forth, right? So let us say my essential criteria is that I want a stick thin woman, right? That's my essential criteria. I want somebody who's stick thin. That is what I consider attractive. Okay. And there's this girl who's slightly plump, but she wants to pass the first line. She's confident that Once she gets talking to me, she will win me over. But she doesn't want to get rejected at the outset, and she knows that my condition is stick thin. So what does she do? She'll wear a black dress and give a side pose and send the photograph. Right? Now I get the photo. What do I conclude? Stick thin, proceed. Is that what I should do? It's like you making a decision by doing a one lead defib strip, right? Imagine the life-changing consequences. Yeah. So what should I do? I should say, I want more views, right? So I tell my mom, please tell them to send some more angles of her, right? So this time what she does, she gives right lateral, she gives left lateral, and she sends 5 photos. Okay, in 4 photos, she looks stick thin. Only in 1 photo, she looks plump. What do I conclude? Do I say 4 photos thin, proceed panlam? Or do I say no, reject? You get the idea? Because that one picture that showed her plump was the picture that picked out the truth. It was in the axis that picked out the problem, the delay in conduction. Right? So you have 12 leads. That's why you have 12 leads. So even if 11 leads are showing a narrow QRS, that one lead which shows a broad QRS was the one that was aligned in the direction of the delay in conduction and hence showed you the broad QRS. It's the only lead that was aligned in the direction where there was delay in conduction. Yeah. So that gave you the truth. And if your criteria was that you wanted narrow QRS, then you have to reject it as broad QRS. Got that? So these are important things to understand. Because without these basic concepts, then otherwise you look at an ECG and then you'll be confused. Okay, is this narrow complex or broad complex? And then how to interpret, if your basal train itself is wrong, then you'll go completely in the wrong track. Right? Okay. Any doubts? No doubts? Okay, thank you. So we'll do some ECGs next time to see how we are going through it. Thank you.